All right. So I mentioned before, everything I've talked about thus far assumes that you have a patent connection between the oropharynx and the trachea itself, that you've had a tracheostomy but not a laryngectomy. Laryngectomy being a surgical procedure where you remove the connection between the pharynx and the trachea. Again, the good thing about a tracheostomy, at least from our standpoint, is that if push comes to shove, if we can't get anything opened up otherwise, you can attempt to intubate the patient from above, or you can attempt to ventilate via bag valve mask from above. When you deal with a laryngectomy, most of the stuff we're going to do is pretty much the same. However, you don't have the backup of, well, I could do stuff from above the stoma itself. You are completely dependent on the stoma to to make our airway, and we're going to have to do everything through that. So we roll up on a patient, and he's had a laryngectomy. He's had laryngeal cancer. It's been out. His larynx is out. It's been out for years, and he's had this thing in place for some time. We know this guy. He calls all the time. First thing we ask is the patient breathing again? And if he's not breathing or he has no pulse, then he probably needs CPR. We can still attempt to oxygenate this person. Now, is there any harm in putting oxygen on his face? No, probably not. It's just not going to benefit him. So yes, the problem would be if we only have one oxygen source because we're in the house and we only have one tank and his oxygen is out or whatever, then yes, you do want to put it directly on top of the stoma only, if I had to pick one, if we know he's got a laryngectomy. However, there sometimes is a little connection in there. They sometimes have had little valves that have fallen out. There might be a little tiny connection between the upper and the lower. So if I have the option of doing both, I would probably still put oxygen on both. But again, if I had to pick one, this guy doesn't have a connection to his oropharynx, so let's just assume that this stoma is the only way that he can get gas down into his trachea. We're again going to ask, is the stoma patent, which is ultimately going to be confirmed by whether or not you can put a suction catheter into it. Now, one of the things that you may find when you see the patient is they may have a cap over top of it. So we're going to want to remove that cap. Why? Because they get clogged up with stuff or sometimes occluded. And so if you remove that cap, which in this case, this is same thing, a heat and moisture exchanger that makes air more comfortable to breathe through these things. We'll want to remove that so that we can prove that there is a patent either tracheal hole underneath there or patent tracheostomy tube. If the patient has some kind of appliance in place, exactly as before, you're going to remove the inner tube after you've taken the caps and stuff off in order to facilitate passage of a suction catheter. Go ahead and take the inner tube out if that's something that's in place. If there is a cuffed outer tube in place, then you're going to deflate the cuff and see if they have any improvement with that. If no improvement, then we're going to remove the tube exactly as we would previously. And the patient should be, hopefully at that point, breathing well, because if not, we've got a little bit of a problem. What you got left at that point should be a open stoma, and if you look in these things, just as an FYI, this is actually a little speaking appliance that you can get. Basically, if you occlude the front of it, there's a little vibrating thing in there that sort of works like your vocal cords. So they do have an ability to phonate if you have one of these things in place. This is a connection to the oropharynx. That's where I was saying sometimes there is a little tiny hole in there if that little plug falls out too. But anyway, at that point, theoretically, if you've gotten any tubes or plugs or anything out of the way, and the patient is breathing on their own, then you're good. You don't have to necessarily take and put anything else back in there if the patient is breathing on their own, saturating relatively well, and is relatively comfortable without a terrible work of breathing. If that's not the case, then your option at that point is to try to ventilate the stoma. Remember before we said, well, we're going to try to ventilate from above, and then we may try to intubate from above, or we may try to ventilate from above and then ventilate the stoma and then intubate from above and then intubate the stoma. In this case, all you've got is the stoma. So you're going to try to ventilate through that. There are means of doing so, again, with a small, like a pediatric size face mask that will work. They demonstrate here mouth to stoma breathing. I will not do that. I have a bag for that, but I suppose somebody out there could do it. If you've been unable to ventilate without having some sort of tube in place and you've checked everything else, then we can try to intubate the stoma itself. If you are using positive pressure, then of course you'll need a cuff tube, and the same rules kind of apply as before. You'll probably want it to be relatively small, a 6 or a 7, something like that. You're not going to be able to jam a 9 down through some of these, although some of these tubes, some of these stomas are actually quite large. But you'll want to put an appropriately sized tube down through there. You want to be very careful doing it. Now, it's going to take a little bit of pressure to get the thing to curve down through the back of the trachea, but it shouldn't take a ton of pressure. It should go relatively smoothly. And if it doesn't, then I'd be very cautious that potentially you're getting into trouble. If you can see the back of the trachea and you can very carefully use a bougie, then that would work. Don't use a stylet on these things to try to railroad over top of, because you're definitely going to get into trouble with it. So, now we've intubated the stoma. We have secured the airway at that point. As long as we haven't gotten into soft tissues or something like that, then we have a patent tube. Now it's just a question of what other reason could the patient have for being hypoxic. Maybe he just needed positive pressure because he's a bad COPD or a bad CHFer, and we just weren't able to get it otherwise. But at this point, the tracheostomy is essentially, or the tracheostomy and the laryngectomy essentially are not our problem anymore. There could absolutely be something else. Maybe they need bronchodilators. Maybe they need, again, positive pressure and Lasix. Maybe they have a pneumothorax that we've just been ignoring this whole time because we've been worried about the tracheostomy. But if you have an ET tube in place at this point, then you have taken the tracheostomy or the laryngectomy out of the equation, and you now have a patent airway. So congratulations, that's good. You may ask, what if I show up and the tube's just fallen out? So family is kind of new at this, and for some reason tube got pulled out, tugged out, it's out for whatever reason. Generally speaking, it's probably going to be okay. If the patient's not in respiratory distress, if the tube has just fallen out, then that's kind of okay. Now, we'll get it sorted out. If it is a fresh tube, then we do want to get something back in place. If they need the tube for whatever reason, we do want to get something back in place shortly. But typically speaking, over a short period of time, most people will be able to survive with just a stoma. So the biggest thing we can do for these guys is don't panic and don't go monkeying around trying to sneak something in there that doesn't fit. If there's nothing that fits but the patient's doing okay, then all right, let's go to the hospital. We'll get this thing sorted out where they've got more equipment, more selections of tubes, and more options rather than trying to do this in the house. But take it easy. Everything's okay as long as the patient's oxygenating all right, and it doesn't have to look perfect. It just needs to get kind of fixed eventually. This might be another one where you take that soft suction catheter and pass it into the stoma to at least make sure that that you keep a little bit of a hole in place. But if the patient's not in respiratory distress, I don't think that I would try to shove a small ET tube or something like that in there unless there's some sort of great reason to, like they have to have positive pressure or something like that. So we talked about now tracheostomies with an intact larynx and laryngectomies where you don't have an intact larynx. And again, the big difference is that if you have a tracheostomy, you can still try to ventilate from above. You can still try to intubate from above. If you have a laryngectomy, you are left with just a stoma. And that's all you're going to have to work with. So everything's going to have to pretty much work through here. That's our basic algorithm for dealing with tracheostomy emergencies, or at least most of them. The cases when you find the patient in respiratory distress where he's getting cyanotic and looking terrible. And most of these, honestly, we will be able to fix with just suctioning. But being careful to do all that other stuff, like get the caps out of the way, remove the intercannula, all that stuff is important as well. But that basic stuff will take care of probably 80% of these tracheostomy emergencies. Say, though, that the patient is not really hypoxic. He's not in respiratory distress. He's not turning blue, but it's a different color that seems to be pervasive throughout the living room of the patient's house. And the patient still seems sickly, but blue's not his color. What do we do then? Well, we'll find out in just a minute after a word from our sponsors.